Hi, everyone. My name is Kelly Macauley. I am going to be leading our discussion today about the cardiac cycle, and we'll do a review of EKGs and things like that. Just a little bit to get to know you guys. Can everyone write in the chat when you are thinking of taking the exam or when you've actually scheduled the NPTE? I see a lot of Julys and Aprils. So a lot of you are right around the corner. July, so pretty well split between the two. That's great. So hopefully this will get you started on a good study path, and it'll give you an opportunity to go ahead and review some of the things that you'll need to know for the exam. I'm just trying to get everybody in the meeting here. So, all right, let's go ahead and we'll get started. So just a little bit about me. My name is Kelly Macauley. I am a PT professor at the Northern Arizona University in the hybrid program. My background is I have a DPT from the MGH Institute of Health Professions and then an EDD from the University of Phoenix in education. A board certified clinical specialist in both cardiovascular and pulmonary and geriatric PT. And I also am really interested in simulation and how that can impact learning and things of that nature. If you As we're getting started here, if you have any questions or anything as we go, please feel free to pop them in the chat. You all can see my screen and hear me okay, right? No issues? I can't really see you, so no issues. Okay, great. All right, let's jump in. So why, for those of you who are taking the exam in April, you probably know that why we're talking about this. On the NPTE, they shifted the questions a little bit in 2024. It didn't really impact the makeup of the cardiovascular and pulmonary content. We'll have about 7 to 9 questions that are on PT exam, 7 to 9 questions sort of on evaluation, differential diagnosis and prognosis, maybe 8 to 10-ish on interventions for a total of 22 to 27 questions from the cardiovascular content, which is just under about 15% of the exam. So that's why we're talking about this here. What we're talking about today is really going to probably help you with the PT exam, but also understanding like your eval and your differential diagnosis and prognosis. All right. So the objectives for this presentation are to describe the electrical conduction system of the heart, to describe the cardiac cycle, identify the components of the ECG, identify some common normal rhythms on a rhythm strip, and then identify some common arrhythmias on a rhythm strip. And then we'll try to answer, do a few practice questions at the end as well. All right, so hopefully this is a review, but we'll do a quick anatomy review here. So the impulse from the heart starts in the SA node, which is the sinoatrial node. It then travels down to the AV node, which is right above the junction, the atrioventricular junction. It then travels down to the bundle of His, and then it will branch at that point, and it will go into the left bundle branch that will supply the left ventricle, and then the right bundle branch. And the branches that go to either side are called the Purkinje fibers. So as you can see here, we have that firing of the SA node. When that fires, it depolarizes down to the AV node, then to the bundle of His, and then we have that bifurcation, and you have the right and left bundles and the impulse goes to either side. All right. So in the heart, there you have an intrinsic heart rate. The normal heart rate, and when you think about a normal heart rate for someone, we think about the heart rate being 60 to 100 beats per minute. And that's if the beat is generated from the SA node. Let's say for some reason there's a problem and it's not generated from the SA node. Your heart can still beat. So if for some reason it's actually the impulse starts at the AV node, there's some sort of block that's prohibiting and that electrical impulse from either being initiated in the SA node or traveling down to the AV node, you can have a heart rate between 40 to 60 beats per minute that's initiated at the AV node. Say both of those are broken. You don't have the SA node, you don't have the AV node. Your ventricle has some, in the myocytes, there's some intrinsic electrical activity that can be generated, and that can create a heart rate of about 20 to 40 beats per minute. The problem is if you have a heart rate that's generated from either the AV node or the ventricle, it's not going to increase with activity. So certainly these people who, someone who for some reason doesn't have any sort of communication between their atrium and their ventricle because of some sort of pathology, usually a complete heart block is the most common reason, they will have a heart rate of 20 to 40 beats per minute, which is really slow, and it will extremely diminish their cardiac output. All right. So what controls the heart rate? Well, there's several things that control the heart rate. First, let's look at the nervous system. So nervous system, as you know, is generated or created from the peripheral nervous system, the autonomic nervous system, the central nervous system. In the autonomic nervous system, we have two components, both the sympathetic and the parasympathetic. And both of these are responsible for controlling the heart rate. Let's look a little bit more into that. So the parasympathetic system really is the primary driver that's responsible for controlling the heart rate, and it does so via the vagus nerve. And what it does is it actually depresses the cardiac system. So it slows the heart rate at the SA node, it reduces the conduction speed through the AV node, and it decreases contractility. And that's really especially in the atria. The cranial nerve 10, the vagus nerve, has more sort of impact in the atrium. So this is the primary system that's working on the heart. However, you can have sympathetic stimulation of the heart, and that's what you heard, sort of that fight or flight response, where you have activation of the beta-1 receptors in the heart. And when we have that fight or flight response, what happens? Well, we have an increased heart rate, which is chronotropy. You have an increased ventricular contractility, which is the fancy word to say that is inotropy. And then you have enhancement of the electrical signals through the heart. So you have an increase in that electrical activity. And the way this can happen is through the nervous system, but you also have a backup system, and that can occur through catecholamine or hormone stimulation. And that's the epinephrine and norepinephrine that's released when you have that sort of fight or flight response. So you have this whole sympathetic system that overrides the parasympathetic normal activity that's occurring. And you do that again when you need to. You're walking, you're hiking, and all of a sudden, you see a bear or something, and you're turning and you run away. Not that you should usually run away from a bear. That's a bad idea. You should back up slowly, but you get the idea. All right. So let's talk a little bit about the segments of the EKG that we're looking at and what they sort of signify. So if you're looking at the components of an EKG, the most common waves that we're used to talking about are the P, Q, R, S, and T. The P wave is what we call atrial depolarization. It indicates when the atria contracts, which is also known as atrial systole. It's also known as the atrial kick. You can hear that all three of those are an appropriate name for that depolarization of the atrium. Then we get into the QRS complex. This is where the ventricle gets involved. And you can see an EKG measures the amount of electrical activity. So this spike is a lot more electrical activity, the QRS spike, than the P wave spike. And that's because the extent of the contraction associated with that in the ventricle is much, much more strong than it is in the ventricle. I mean, the atrium, sorry. And then you have the T wave. We also have a couple more. You can see these outlined in blue here. These indicate intervals that we can be concerned about when we're looking at an EKG. So you have the PR interval, the QRS, the ST, and the QT. And I'm going to move to the next slide and talk about these a little bit more in relation to what's happening in the heart and the cardiac cycle. So here we have a picture again of that same EKG. And on the bottom, we have in sort of this yellow orangey flavor color. It sort of looks like orange sherbet to me. This is what's happening in the atrium. And then on the bottom, we have the purple, and this is what's happening in the ventricle. So let's look at the atrium first. So during an atrial, anytime we're talking about diastole, we're talking about relaxation. So when you're thinking of a blood pressure and we're talking about the systolic and the diastolic numbers, diastole is we're measuring the pressure in the heart when it's resting. Systole is contraction. So we're measuring the pressure in the heart when there's a contraction, essentially. So when we're talking about atrial diastole, we're talking about when the atrium's resting. And the atrium's resting almost the entire cardiac cycle, except for during this PR interval, so which goes from here to here. That's when we have that sort of end of atrial diastole and boom, atrial systole. And remember, atrial systole is the atrial contraction, and it's what we a lot of times call the atrial kick. Because remember that most of the time, the filling from the atrium to the ventricle is a passive process, and that's occurring during this atrial diastole. Let's talk about the left side of the heart. So what we're thinking about is that mitral valve is open and blood's just sort of going from that left atrium to the left ventricle. The pressure is higher in the atrium than the ventricle. So the blood moves from a higher pressure area to a lower pressure area. And it's just a passive process. Except right at the end, we get a little bit of boost. We get a contraction to really push all that blood out so we can get it into the ventricle. And that's what we're seeing happen. And the electrical capture of that is that PR interval, and most specifically, that P wave. That's indicating that initiation of atrial depolarization. Let's now look at the purple, what's happening in diastole. So again, about 2/3 of the cardiac cycle is ventricular diastole, and about 1/3 is that ventricular systole. So the initiation of ventricular systole is during that QRS, and it spikes right there at that R, the peak of that R wave, when the ventricle really is depolarizing. And this is where we get that contraction time. And then we go back to diastole where the ventricle just relaxes, and then we have that passive filling again from the atrium. And that contributes to the cardiac output that's ejected to the rest of the body, especially when we're thinking about the left side of the heart. If it's the right side of the heart, it's the deoxygenated blood that's getting pumped and pushed out into the lungs to get reoxygenated. So again, the atrial systole is that P wave, and that indicates that contraction, that initial depolarization of the atrium. And then that QRS is where we're getting that ventricular depolarization or contraction and the initiation of systole in the ventricle. And that's really what's happening in one cardiac cycle. All right, so let's talk about the picture that we see when these things are happening. So we'll see that with an electrocardiogram. And these are the most common ways that we as physical therapists will assess someone's cardiac rhythm. most often in a PT clinic, you're going to see either a 3-electrode system or a 5-electrode system. And it may be attached to telemetry, like portable telemetry, which we see here in the 5-lead system. This looks like more like a Holter monitor, which is something that may be done at home. This is something we can also hook up to a probe rack or one of those portable monitors to give us an idea of what's happening. The 3-lead and the 5-lead give us a completely adequate picture of the heart. And what it's showing us usually is one view of the heart, where a 12-lead EKG can give us multiple snapshots because of the electrical configuration of the leads that's on the patient. And you can see that lying here with him lying down. Now, in most cases, we don't need that level of monitoring for somebody in physical therapy. Let's take a quick look at who needs that level of monitoring. So we're going to use this ACSM risk stratification. So you have a patient who comes in, you're reviewing their health and medical history. If it's someone who you know has cardiovascular, pulmonary, or metabolic disease, then this is someone we're putting up that's at high risk. They haven't seen a physician before, then it's someone who probably should. And this is someone who may need who will need an MD at max or submax exercise testing, and that's someone who should have a 12-lead EKG because it's going to give us a better picture of what's happening at the heart at all times because it gives us different snapshots from different angles. Let's go back up here. If we have someone and they don't have any known disease, so then do they have any signs or symptoms of cardiovascular, pulmonary, or metabolic disease? So is this someone who's short of breath? Is it someone who has like peripheral edema? Someone who's got a lot of abdominal obesity, any of those things that are some signs or symptoms of cardiac disease. Maybe they get dizzy when they're doing activity. Any of those types of things. Then again, if it's a yes here, then they're at moderate risk. So they may need a medical checkup, maybe not. And if you're going to do a max exercise test, this is again when a physician's needed, and again, a 12-lead EKG would be needed. If it's someone who doesn't have symptoms and they don't have a lot of, and if they have more than 2 risk factors, again, they're in that moderate risk category. But if they don't have a lot of risk factors, then that's someone who there's no need for a medical checkup. And we can do any sort of exercise test, and the 3 or the 5-lead may be completely appropriate. And the moderate risk folks, as long as we're not doing a max exercise test, as we're doing a submax exercise test, then again, that 3 or 5-lead EKG is completely appropriate for us to use, just to make sure that nothing's happening to monitor that. But since we're keeping it below that max level, we don't need that 12-lead to give us a full picture of the heart. All right, so let's circle back. So what do we see when we're looking at the printout? Well, the 12-lead, which is what we have over in the picture, gives us a complete electrical picture of the heart, and it's used for medical diagnostic purposes. So in the previous slide, I was showing you how there's different risk stratification. If you're trying to diagnose if the patient has a cardiovascular problem, this is really helpful because these different leads correspond to different parts of the heart, and I'll show you that in a second. But as I was saying, it's not necessary or practical to have a 12-lead on for most PT evaluations and treatments. It's only for those really high-risk patients and if you're going to be exercising them at a high level. If you're staying below a submaximal level, then it's really not necessary. So in most cases, we use that 3 or 5-lead, and it gives us 2 pieces of information in real time. The first piece it gives us is it'll give us the heart rate. And that way we don't have to keep calculating it as the patient may be exercising or doing activity. So that's really useful. It'll also tell us if there's an arrhythmia. And we can use that to tell if something dangerous is happening as the patient's doing activity. Because as we all know, there could be people out there that have underlying cardiovascular disease, even though they don't have any risk factors or we don't know about the risk factors. And so there's always a chance someone could have an abnormal response and have a dangerous arrhythmia. So this helps us to understand and be able to see that before there may be any detrimental effects. So what are we looking for when we have a 12 lead, or if we do? Well, one of the things we're looking at is whether there's ST segment. We're looking at this ST segment to see if there's elevation or depression. Now, how do we assess that? Well, when you have an EKG, it basically revolves around what we call the isokinetic line. So if we look at this EKG, we can see basically, it's invisible, but you can basically spikes above and below sort of this invisible line. And the ST segment should be really resting on that invisible line. If it's above that invisible line, like we see here, and it needs to be at least 2 to 3 millimeters above that, then we call that ST elevation. Similarly, if it's below that, we call that ST depression. ST depression, in 80% of the cases, give or take, indicate that the person is having myocardial ischemia. So ischemia means decreased blood flow for the given demand. If there is an ST elevation, which we see in this middle picture, that means that the patient is having an infarct. Infarct is worse than ischemia. It means that there was ischemia, but now we have permanent damage that's caused an infarct. So that's worse than the ischemia, because if there's ischemia, we can either, if it's with activity, we can decrease the activity level and allow the heart to catch up and go from there. Or they can have an intervention if they're doing this for diagnostic purposes, where they can hopefully open up the blood flow before there's an infarct happens. If an infarct's already happened, we want to make sure that we can allow the patient to recover like any soft tissue injury, so the least amount of permanent damage is there. Let's take a look at this picture on the right. So as I mentioned before, we had I'm just going to flip back for 1 second. We have these 12 leads here. And the same leads are here, but you'll see these boxes around them. So if you combine 2, 3, 4 of these leads together, it can tell you if there is damage to a particular part of the heart supplied by one of the major vessels of the heart. So if you look at this sort of royal blue color, if we have an issue in this lead 1, AVL, V5, and V6, there has to be abnormalities in all 4 of those, then we know that either the lateral circumflex or the diagonal artery is involved. And the areas of the heart that are supplied by those arteries may be clogged or something's going on. Maybe there might be a vasospasm, it could be an embolus, it could be a plaque, it could be any number of things, but we know that's the area of the heart that's involved. If it's lead 2, 3, and AVF, these 3 here, then we know it's an inferior issue. So it's probably the right coronary artery. It could be the circumflex, but that could be there. Similarly, over here, if we know that these are involved, it's probably the LAD, the left anterior descending. And if it's V1 and V2, it's probably septal, which is right in that middle where the septum is in the heart, or it could be anterior if it's V3 and V4 that are involved. So these abnormalities in these leads give us a picture of what part of the heart is impaired. Again, this is most likely going to be used for diagnostic purposes. And if you work in a lab or something of that nature, this level of detail might be helpful. If you don't, then on an everyday practice level, this probably is sort of irrelevant to you. However, I wanted to review it so that if you see in the chart someone had EKG changes in any of these areas, this is where that's coming from, and this is why or how the physicians or cardiologists use this information to determine what's wrong with the patient. All right. So let's talk about reading rhythm strips, and then we'll look at a few different EKGs. So one thing that I usually tell students when they're learning how to read a rhythm strip is to come up with a system and stick to it every time. You want to do the same thing every time. So I usually have them start off with looking, is it regular or irregular? And if it's irregular, is there a pattern to the irregularity? So every other one does something wonky, but then on the other beats, it's normal. Or is it completely random? It's completely random. That means it's irregularly irregular. Being able to distinguish the type of irregularity will help you to determine what type of abnormal rhythm it is. Because certain abnormal rhythms have patterns to them and others don't. So it helps you to rule in and rule out what type of rhythm it is. It's really important to note if there's P waves. Remember back to where we started. A P wave indicates that the atrium's contracting. So if there's a P wave, it's telling us that the atrium, that the impulse of the beat started in the atrium. If there's no P waves, then it's telling us that the beat's starting somewhere else. Maybe it's starting at the AV node, maybe it's starting somewhere in the ventricle. But again, that's going to help us identify what kind of arrhythmia it is. We can figure out what the heart rate is, because if it's really slow, that's going to be one type of arrhythmia. If it's really fast, that's another type. We also want to know, is each P wave followed by a QRS? I mentioned before, the most common arrhythmia where that doesn't happen is complete heart block. So you have P waves going on, and then you have QRSs, but they're happening at random, and they're not that nice depolarization pattern that we were talking about before. The other piece that we want to talk about is the QRS complex. And we want to see, do they look the same? If they don't, then that's going to tell us of one type of arrhythmia or not, again. And what we're really looking for is the width. We don't care so much about the height. That's useful for medical diagnoses. For us, we're looking at the width. Is it narrow or is it wide? If it's narrow, it's telling us that the beat went through the normal electrical pathway that we talked about earlier. So that SA node, AV node, down to the bundle of His and through the Purkinje fibers. If it's wide, it's telling us that it originated outside of that pathway. And usually that means it originated in the ventricle. And we'll look at a couple examples of that in a second. So these are the things that are really helpful for you to think about when you're trying to identify what type of rhythm that we have. And I have a couple other tips just to help you out. In most cases, P waves look the same. If you aren't sure if a blip is a P wave, find another one that you sure is a P wave and see if they look the same. If not, it probably isn't a P wave. Okay, so that's really important to think about. Like I said, the QRS height for our purposes doesn't matter. I don't want to say it's irrelevant. For our purposes as a physical therapist, for the most part, it doesn't really matter. You're looking at the width to see, is it within normal limits? If it is, then it's a QRS. I mean, it's coming from the atrium. If it's really wide, it's telling us it's coming from somewhere else. When you're counting the heart rate, make sure that you count full beats. You don't want to go in the middle of a QRS or a P wave. And you always want to use the longest strip possible to calculate a heart rate if it's irregular, okay? Let's take a look at these and sort of work on looking at these things. So this is a normal EKG or ECG. So we have a P wave and a QRS and a T wave. A P wave, a QRS, and a T wave. We want to look, is it regular? One of the easiest ways to see if it's regular is to take a piece of paper and mark it right at the peak of each QRS and then see if the distance is the same between each QRS peak. If it is, then it's regular. You also want to figure out if the heart rate, and here we know it's normal, so it's between 60 to 100 beats per minute. Someone with a normal EKG, no problem, we can go ahead and treat them. And that's really the question you want to be asking yourself every time is this someone I can treat or do I have to do something different? And if I have to do something different, what is it that I need to do differently? Is it something that, I just can't exercise them? Or is it something where I need to go ahead and call is it something that like I need to, emergently call 911 or something like that? All right. This next one, whoops. Oh, no, it went. This next one is artifact. And it's really important to be able to recognize artifacts because if you don't, it almost always looks like it's something really dangerous. Oftentimes it looks like it is VTAC or VFib, and it's not. So it's really important to notice. So what are the hallmark signs and symptoms of that? Or signs, really. So you see here in the beginning where it looks like it's a 6-year-old scribbling. If it looks like someone took a crayon and scribbled, and it's got really dark lines, like in this beginning here and in the middle, then that's not a real reading. You don't get a really thick, dark line if it is a normal rhythm. It's usually nice and fine, like we'll see in some of the other ones. So that's really the big way. The other way you can tell is what's called a wandering baseline. And remember how I said there was that isokinetic line that usually goes up and over, where the electrical activity goes up and over. That goes out the window, and it basically looks like it's really wavy, and it has no like it's not on a straight line, I guess. That's the other way to tell that it's artifact. What you want to do if you notice artifact is figure out what the reason is. Oftentimes people are wearing old electrodes. I'm having word finding problems with this one. So they have old electrodes on. So when they do that, they don't stick very well. So you're getting some, some like they might be sweaty or something like that. If you have someone who's like, especially someone who's like someone who's got a really hairy chest, that may be a problem because they don't stick very well. If you have someone who is really cold or something, maybe shivering, something like that. Like all of those reasons are really sweaty. They're all reasons why the electrodes won't stick. So that's pretty easy to figure out. I see a question. How do you calculate a heart rate based on this lead? So if you're like the artifact lead, if you have artifact, then you can't calculate the heart rate. You need to fix the problem first, and then you can calculate the heart rate. But there's no way to calculate a heart rate of artifact because it's not a true representation of the electrical activity of the heart. All right. Sinus bradycardia, you'll notice that you have the P wave, the QRS, and the T wave, like we saw in a normal sinus rhythm. The only difference is the heart rate is less than 60 beats per minute. And this isn't necessarily dangerous. I'm sure some of you have a resting heart rate that's less than 60 beats per minute, and that may be okay. So this is where it's really important to take in the context and a little bit more information about the patient. If it's someone who's well trained, if it's someone who just has a low resting heart rate, that's perfectly fine. If it's someone who is an older adult, by the time you're 75, you only have about 10% of your pacemaker cells left in your SA node. So older adults who are at a huge increased risk for having arrhythmias. So if it's an older adult who has bradycardia and it's not their normal, that may be something that's becoming more of a medical emergency or something you at least need to let the physician know about. If it's someone who has just started on a cardiac medication, like specifically a beta blocker, so it's stopping that blocking those beta 1 receptors in the heart, then that may be something that you're like, maybe we need to talk to the physician. Maybe they have too much of the beta blocker on board. So any of those things, so you need a little bit of context to determine if the sinus bradycardia is bad or good. Again, if not, then it's perfectly okay to treat them. So how would you calculate the heart rate based on this lead? So if you're looking at the paper here, you have a big box that's here, and then you have little boxes. Each big box is 1 second. So, and then you have these hash marks that are at the top. These hash marks, let me just double check, they should be 15 seconds apart. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. So there should be 15 of those boxes in there. And all EKG papers the same. So from this hash mark here to here is 15 boxes. And so that is 3 seconds. And then we have 3 seconds here. So this is 6 seconds long. So what you do is then you count the number of QRS spikes that are in there. So we have 1, 2, 3, 4, 5, 6. So this one is right on the cusp of being bradycardic, because if you have 6 seconds long, to get to 60 seconds, you have to multiply that times 10. So, and we have 1, 2, 3, 4, 5, 6 beats in here. So that would mean that our heart rate is 60 beats per minute. Does that make sense? And you would calculate it similarly on any EKG. The difference here, now we're going to talk about sinus tachycardia. So again, it's the normal sinus rhythm. We have a P wave, a QRS, and a T wave. The T wave gets pretty smushed here when the heart rate increases with the P wave. So sometimes it looks almost like they're on top of one another. And that can happen if the heart's really fast. But you have the normal components here. But it's just that the heart rate is greater than 100. Now, again, sinus tachycardia is not a bad thing. Sinus tachycardia, think about what happens when you run. You're in sinus tachycardia. Your heart rate goes up to meet the demand of the activity. So that's not a bad thing. It's a bad thing if it gets too high for somebody who has underlying cardiac disease. But in general, most people can tolerate sinus tachycardia. If it's greater than 100 at rest, it's good to ask a few more questions. Is it someone that's had a couple of Red Bulls or a lot of caffeine, so their heart rate's up? Or is there another reason why their heart rate's up? Do they have an infection? Are they dehydrated? Something like that. Or are they just someone that normally rests high? There are some people that are like that. The one thing that you want to think about is when you get to a heart rate of about 115 to 110, or 120, I'm sorry, you have decreased diastolic filling time. So if we're thinking about that cardiac cycle we were talking about when we started, you can have you have decreased, if your heart's beating 120 times a minute, so that means every half a second it's contracting, you don't have a lot of time to fill. So you're not going to have as much blood in your heart. If you're normal, that's okay, because you can increase the volume, the stroke volume and things like that to maintain your cardiac output. If you have someone with a problem with and they're not able to increase their stroke volume, then tachycardia could lead to an abnormal response to activity. Let's talk about atrial fibrillation. So now we're getting into one thing I do want to say that is the sinus and the bradycardia and sinus tachycardia are both atrial arrhythmias. And let me just go back here. And these are normal QRSs. So like there's a normal pathway starting from the SA node down to the AV node and, throughout the ventricles. This is also normal. But the difference here is if you measure the distance between the black dots, like from here to here and here to here, it's going to be different. So that's telling us it's irregular. The other piece to note is the difference between the first set of black dots, the second set, the third set, the fourth set. It's all different. So that's telling us there's an irregular rate. So there's no pattern to the irregularity. That's a hallmark sign of atrial fibrillation. The other hallmark sign of atrial fibrillation is no P waves. So let's remember back to the cardiac cycle. What does that mean? If you don't have any P waves, that means your atrium is not contracting. So you're losing that atrial kick. You don't have an ability to get that last bit. And depending upon where you look, it's 20 to 30% of the volume from your atrium to your ventricle. So you're at risk for having decreased cardiac output because you don't have that atrial kick, and you may have long periods of time where you don't have a ventricular contraction. And the reason that's happening is it's a narrow QRS, so we know the impulse is coming from the atrium. However, it's not coming from the SA node. And so it's coming from random areas that are firing in the atrium. So, and since it's random, we don't know when it's going to happen. So it can lead to a decreased cardiac output. If the heart rate is controlled, and that means we're less than that 115 to 120 mark, then this person, even though it's irregular, it's okay to treat them as long as it's not a new arrhythmia. If it's new, like you walk in one day, this is really common after cardiac surgery, you go to treat the patient, and you're like, whoopsie doopsie, they're in atrial fibrillation today. Then you need to talk to the medical team and what have you. But if it's someone that we know has atrial fibrillation and their heart rate's controlled at rest, no problem with exercising them, because it's not gonna, they're still gonna have enough cardiac output to tolerate the activity. The other key thing to remember here, remember when I said that if the heart rates are regular, you want to take it as long as possible. So for this person, if you're trying to evaluate what their heart rate is, you want to try to take it for a minute if you can, because of that irregularity. If you take it for too short a time, it may be when the beats are really close together or really far apart. So it'll give you a really skewed value. You want to take that average over time. All right, atrial flutter. So atrial flutter, the difference between atrial flutter and atrial fibrillation is atrial flutter is regular usually. So you see how every almost 3-ish boxes, we have a contraction, a QRS like ventricular contraction. The difference though is we have multiple P waves before we have a ventricular contraction. That's the hallmark sign of atrial flutter. Oftentimes it's called the sawtooth pattern, because if you look at the teeth of a hand saw, this is what it would look like. Like you have these P waves are like those little teeth. So you may have 2 to 4 P waves per QRS complex is what we have here. So if you count the number of P waves, the heart rate's going to be super fast. It may be well above 200. It's okay though if the ventricular rate, which is the number of QRS complexes, is normal. And by normal, we're shooting again between 60 to 100. Because that means there's enough time, even though the atria is contracting really fast and pushing that blood out really fast, it's allowing the ventricle to fill. And if the ventricle fills, that's okay. We're going to have enough cardiac output. If their heart rate is above that 115, 120 mark at rest, then they don't have enough time for filling, so then they may not have an appropriate response to activity. All right, let's talk about a couple of more dangerous ones. Generally speaking, ventricular arrhythmias are a lot more dangerous than atrial arrhythmias. And the ones we just talked about were the atrial arrhythmias. The ventricular arrhythmias are the ones that really can lead to more bad consequences, I guess. I want to point out on this slide, remember how I said, like, let's look at this first QRS complex. That's narrow. That means this, we have a P wave, QRS complex, P wave. Perfect. We know that came from the atrium, and we know that that's going through the normal electrical system. Boom, let's look at this bugger. This is super wide. The distance from here to here is almost 2 full boxes, where this guy is only maybe a half a box. This guy is abnormal. Oops, sorry about that. When it's that wide, it's telling us it's coming from somewhere else. And most often it's coming from the ventricle. And what we have here is a premature ventricular contraction. And what that means is your ventricle's contracting because there's some sort of site within that ventricle that's causing the increasing the excitability of the myocytes in the myocardium of the ventricle, and it causes it to contract. It initiates, in other words, it initiates depolarization. When that happens, it's contracting earlier. That's why it's a premature ventricular contraction. And when you have something happen prematurely, it hasn't had enough time to fill. Let's look at this. Do you treat someone who has PVCs? Well, yes, you can. There's a couple of things to think about. There's no atrial kick because you don't have enough time for that to happen because it's contracting early. And that decreases you have decreased diastolic filling time because it's also contracting early. So you have less volume in there. If that happens every once in a while, there's absolutely no problem. So if you have less than 7 of those in a minute, it's really okay to treat the person because the body can accommodate and there's enough filling in there. If you have more than 7 in a minute, then you're at risk for having decreased cardiac output, and it can impact the person's response activity. So like anything, if it's new, it's time for a discussion with the medical team just to see where they're at. Are they going to try some medications? Do they think it's an electrolyte abnormality? Like, why do they think it's happening? If it's known and the patient's hemodynamically stable, good blood pressure, heart rate is okay, despite the rhythm, they're having a response to activity, then it's okay to treat them. But it's definitely a conversation with the the medical team if it's something that's new and they're having a lot of those. I want to circle back. So we had a question of why is the QRS inverted? It depends where it's telling us that the electrical impulse is coming from a different place. So it's depolarizing the Purkinje fibers in a different way than if it were to come from the SA node. So again, it's just it's basically taking a snapshot of the electrical activity of the heart, and it's happening backwards and it's wider, so it's taking longer for that to happen. With one PVC, do you terminate extra immediately or allow the patient to if it's just one PVC, allow them to keep going, but definitely keep an eyeball on there and try to count to see if there's less than 7 a minute, just keep going. It's no problem at all. If it's more than 7, then that's when you really want to think about stopping exercise. But just one, and if I took EKGs of all of us right now, all of us, we'd have some PVCs just sitting here, even without a known cardiac problem. If you had a lot of caffeine today, you're going to have more PVCs. So there's some normal reasons why, and they're a normal variant. It's just if you have too many of them, it's a problem. Hopefully that makes sense. And there's a couple of fancy names for types of PVCs. If you have a PVC every 3rd beat, that's called trigeminy. If you have a PVC every other beat, so you have a normal one, a PVC, a normal one, a PVC, that's called bigeminy. If you have 2 PVCs together, then that's a couplet. And if you have 3 together, that's a triplet. Any of these, if you have 1 couplet and 1 triplet, if that's all that happened, then that's fine. It's not really a big deal. If you have several of those in a minute, then going back to our previous slide where we said if you have more than 7, then that's not good. If the bigeminy and trigeminy, If some people live in that and they're perfectly fine, and you may know somebody, maybe you yourself has that for whatever reason. Again, if it's something that's known and someone has it, they can usually tolerate activity, and especially if it's not new, they may be completely acclimated to that. If it is new, then again, these are things that we want to have a conversation with the medical team and just make sure that there's nothing else going on. We start to get a little bit nervous if we have 4 or more in a row. That's PVCs in a row. That's when it starts to get a lot more dicey. If you have 4 to 30-ish or 30 seconds, that's called non-sustained ventricular tachycardia. If it's only 4 and that's it, and then we stop, that can be okay. But if you're having runs where you're having multiple of those, you really need to stop. The patient is at risk for decreased cardiac output. I have treated patients. I used to work on a heart failure floor. And so those people have a lot of ventricular ectopy or a lot of PVCs. So it was the normal for that patient. So we would do activity. But again, that's something you're going to talk about with the medical team to make sure they're not going to do something different for that patient. Because the risk of this decompensating, which means it goes from non-sustained ventricular tachycardia to sustained ventricular tachycardia, is pretty high. So let's take a look. And this is sustained ventricular tachycardia, which is just constant, essentially PVCs. So you're not having good filling time and you're not able to really maintain your cardiac output. This is a medical emergency. This is a person who needs to be shocked. They need a defibrillator. And you just need to get them safe and they need to get medical attention. If this can decompensate to ventricular fibrillation, which is even worse. Again, a medical emergency, person needs to be shocked. And these are the 2 rhythms, ventricular fibrillation and ventricular tachycardia, that can be shocked. And what you do when you do the defibrillation is you're trying to shock them out of the rhythm. You essentially stop the heart and hope that it restarts again in a normal rhythm. This is when you don't want to see. This is asystole, and you're looking at no electrical activity. You need to, the first thing you want to do in every case when you see this is look at the patient. If they look okay, then the leads probably fell off and they're not dead. If they look bad and they're getting really gray, their eyes are rolling, that's when you really need help and you need to initiate CPR. You want to get this person help as fast as you can. If this is really a medical emergency and they need to figure out why there's no rhythm. Not all rhythms respond to an AED, and asystole is one of them. It doesn't respond to it. The VTach and VFib are the only shockable rhythms that will respond to AED. So if you have asystole, they need to get into a hospital really fast. And you can always call out for help, and the AED will tell you if it's shockable or not. And if it's not, then you just do CPR. All right, let's take a look at a couple of questions. Oh my goodness, I need to initiate the poll. Give me 1 second. All right, we're just gonna, whoopsie, ignore that it says lymphatics on there. All right. All right. So you enter a patient's room and you scan the telemetry. Which rhythm do you think that this is? Go ahead and, oh my goodness, I can't use this one. Hold on. Let's try this one. Give me 1 second. Sorry about that. We're just gonna launch this poll instead. Okay, so go ahead. You should be able to go ahead and choose now. Oh wait, there goes someone. Will it not let you just do one? Here, let me go through. Okay, all right. Sorry about that. Let me get back. Boo, boo, boo. We'll try one more time. Here, try one more time. Sorry about that. I forgot to take a look at that beforehand. There we go. Now we're cooking. All right, I'm going to go ahead and end the poll. Let's take a look at that. So the majority of people said A, and then we had sort of a smorgasbord at B, C, and D. So let's talk through all of those. So remember, sinus tachycardia, for something to be labeled a sinus rhythm, it has to be regular. And the only thing that makes sinus tachycardia different than a normal rhythm is it's fast. So this rhythm is fast, you're right, but it's not regular. And the way we can tell that is if we look at like the peaks of the QRS from here to here and then here to here, it's not the same number. And you can eyeball it. We have 2, 4, maybe 7 little boxes. And here we have 2, 4, 6, 8 boxes. And then here we have 2, 4, maybe 5 and change boxes. So that's definitely irregular. So if we have an irregular rhythm, that knocks out sinus tachycardia. And it actually usually gets rid of atrial flutter. And first degree heart block too. So the fact that this is irregular actually tells us it's atrial fibrillation. The other way we know this is atrial fibrillation is there's no P waves. And this is a really hard one to look at. But if you look, there's no P waves here. That's not a P wave. There's no P wave here. There's no P wave here. So their lack of P waves rules out B, C, and D as well. So let's look at the next one. So this is the same thing. We have someone who's in atrial fibrillation. I'm going to relaunch the poll. Yes, okay. What type of thing do you think you might focus on in your treatment? All right. Good number who. Oh, we have a dead heat. I'm going to end the poll just for that. So as you can see, we have a couple of people who said A, and then we have a tie between C and D. So let's take a look and figure out which one is the right answer for that. So the first thing we want to look at is no one picked initiator-resisted exercise program due to the rhythm. That's probably a good choice. You could focus on breathing and relaxation. That's not wrong. But is there a better choice? So we're down to proceed with the planned aerobic conditioning or walking program, or defer the treatment and discuss with the medical team. So we've already identified that it's atrial fibrillation, so it's an irregular rhythm. One of the questions that I didn't give you the answer to is whether this is new or not. So you might say, well, Kelly, if it's new, then I would definitely do D. And I would say, okay, that's fair. And if it's someone who it's not new, then I said you could exercise with someone in atrial fibrillation if it's not new, 100%. However, the other piece that you need to consider here is the rate. And the rate here is 204. So because the rate is so fast, we're going to do D, defer treatment and discuss the rhythm with the medical team. They need to do something to slow down that heart rate. So as you're thinking about these and how you're going to make decisions about them, make sure you're thinking about like those systematic things that I pointed out before. Because again, you have to take in multiple pieces of information to determine if you're going to treat them or not. So again, in atrial fibrillation, it may be okay to treat them, but their heart rate needs to be below 115, 120 at rest. Or they're not going to be able to maintain their cardiac output. So if we're up over 200 at rest, that's not, we need to talk to the medical team. Hopefully they know, but if they don't, let them know. All right, we are out of time. Oh, how I got to the 204. So again, you have, there's 25 boxes, which is 5 seconds. And then what you do is then you count the QRS complexes. So we have there's 17 QRS complexes in 5 seconds. So you essentially, and to get to 1 minute, you multiply 5 by 12. So then you multiply the 17 by 12, which gets you to 204. Hopefully that makes sense. All right. I want to thank everyone for your attention and thank you for coming. If you have any other residual questions, just let me know. Otherwise, good luck to you all on your exam, whether you're taking it in April or in July. Have a great night.